In summary, there are more treatment options, but access could be an issue. Vaginal estrogens are more widely recommended, even for people with a history of breast cancer. HRT risks might not be as bad as some of NICE's data suggests. Menopause guidelines in the UK have been outdated for ages, but NICE have recently updated them for the first time in nearly a decade. So menopause care has shifted massively since 2015. Awareness is higher, the demand for HRT has skyrocketed, and the British Menopause Society has become the go-to for evidence-based menopause care. But NICE has finally caught up with some long overdue updates. The first change you need to know about is that CBT is now an official treatment for hot flushes and night sweats. Yes. NICE recommends menopause-specific cognitive behavioral therapy as a treatment for the vasomotor symptoms of menopause, such as the hot flushes, the mood changes, and even insomnia. This can be either alongside HRT or instead of it. Now, the evidence for this isn't amazing, but because CBT is safe with no real side effects, it is worth considering. The main issue with this is that specialist-trained therapists are needed and access to them would be limited. The second is that they've changed the way that we talk about vaginal symptoms. So the term urogenital atrophy is now gone. Because let's be honest, no one wants to be told that their genitals are withering away. It's now called genitourinary symptoms of menopause. And here's what NICE recommends. Vaginal estrogen should be the first line treatment for dryness, discomfort, or recurrent UTIs. Lubricants and moisturizers can also be used alongside them. And if these topical estrogens don't work, we can also consider vaginal prasterone or oral ospemifene. It's a bit of a mouthful. As a second line option. Now, previously, these type of estrogens were completely off limit for anyone who'd had a history of breast cancer. But now, NICE says that they can be considered off license if lubricants and moisturizers haven't worked. Unless, of course, that person is on something called an aromatase inhibitor. Now, there is still limited data on whether vaginal estrogens actually increase the risk of breast cancer recurrence, but the doses absorbed into the bloodstream are tiny. However, the British Menopause Society isn't fully on board with this recommendation, and they still advise involving a specialist before prescribing. The third is that they've now changed the way that they talk about risks of HRT. So the old guidelines used to have tables full of scary statistics about the risks of heart disease, breast cancer, and blood clots in HRT users. But now they've replaced this with specific health outcomes and decision aids for GPs to help patients weigh up the benefits and risks a bit more clearly. But unfortunately, the British Menopause Society is not happy about some of NICE's conclusions. They flagged two major errors in the guidance. The first is the claim that HRT increases ovarian cancer risk, which isn't backed up by randomized control trial data. And the second is the claim that HRT slightly increases breast cancer mortality, which also isn't statistically significant. These changes have been challenged, but they have still made it into the final guideline. In summary, there are more treatment options, but access could be an issue. Vaginal estrogens are more widely recommended, even for people with a history of breast cancer. HRT risks might not be as bad as some of NICE's data suggests. So do me a favor and send this to someone who's going through the menopause.